Hello everyone and good evening. Thank you for joining us on this beautiful summer night for a talk on modern joint replacement with Dr. Lighthart. Just to introduce myself a little bit, my name is Jaime Jackson. I'm a registered nurse. I've worked at St. John's Health for 21 years. I've been in charge of the joint replacement program since 2015 and very involved in the evolution of this program probably for at least the last 12 or 13 years. It's my pleasure tonight to introduce Dr. William Lighthart, or Drew Lighthart, to talk to you about joint replacement.
Thanks. I'm Drew Lighthart. I'm an orthopedic surgeon who's relatively new to Jackson, but I've been in practice for 14 years. I am a subspecialist fellowship trained in joint replacements, which historically has meant hip and knee replacements, and that is my specialty. There are other joint replacements done, but hip replacement and knee replacement are by far the most common joint replacements. I went to medical school in Buffalo, New York, which is where I'm from. I did my residency training in Baltimore for 6 years, and then my subspecialty fellowship training in hip and knee replacements at Rush University in Chicago. Prior to coming here, I've been in practice for 13 and a half years in Vermont, and recently, over this winter, came here. Thanks everyone for joining us. I'm going to give a version of a talk I've been giving for quite some time. This is the first time I will have done it without a live audience, which is a little bit unusual, so bear with me, and I'll try to get through the information. We do have a bunch of questions that were submitted ahead of time, and we've added a little bit to that, some of the usual questions that people have when I've given this talk, or people have given versions of this talk in the past, so we'll try to get through all of that. So as Jamie said, my talk is titled Modern Hip and Knee Replacement. What is it and who's it for? This talk used to be titled Minimally Invasive Joint Replacement. I would argue that now most surgeons in the country, most surgeons in the world who do hip and knee replacements are using some, if not all, of the concepts that used to be unique to minimally invasive or less invasive surgery. So why are we doing knee replacements? Why are we doing hip replacements? Some about the anatomy of the hip and knee is important to know when we start talking about what we do and why we do it. The knee is made up of 3 surfaces or 3 bones: the thigh bone, the shin bone, and the back of the kneecap. When people develop arthritis, arthritis is a word that just means joint inflammation. We are being a little more specific in this case. Joint inflammation for some specific reasons, wearing away, wearing thin of the smooth gliding surface cartilage. There are a bunch of reasons that can happen, but all of them yield essentially the same result. We have little particles of cartilage floating around in the joint. Those irritate the lining of the joint, and we actually have pain in an arthritic joint, whether it's the hip or the knee or any other joint in the body, indirectly. What I mean by that is cartilage and bone don't have nerve endings, but the lining of the joint has some really sensitive nerve endings. So I always use an analogy. It's like getting sand in your eye. If you get enough sand in your eye, it will get inflamed and hurt and swell and tear, and our joints kind of do the same thing. But in that case, the source of that sand, so to speak, is one's own body and the wearing away cartilage. So the symptoms people have, no matter how that occurs, are pain and stiffness and eventually wearing enough material away that joints can be at angles and have deformity. Hip is a little bit simpler joint when we're talking about it mechanically. It's a ball and socket. Both the hip and the knee have lots of supporting structures around the joint, muscles and tendons and ligaments and all of the things that attach one bone to the other. Arthritis, as I said, is wearing away, wearing thin of the smooth gliding surface cartilage. It can happen for a bunch of reasons. The most common type of arthritis is osteoarthritis, or sort of generically wear and tear arthritis. Basically, no good reason that we can think of. People can have post-traumatic or post-injury versions of that. They can have it related, we think, maybe to activities, but most cases of osteoarthritis where we can't point to a specific injury are genetic, and we just don't have a great reason why. Inflammatory arthritis, rheumatoid is the classic, but there's a whole list of inflammatory types of arthritis, including psoriatic arthritis and lupus and all of those types of things. loss of blood supply. Basically, you can either damage the surface that then eventually damages the underlying bone, or the way I think of the loss of blood supply type of arthritis, or osteonecrosis, is we kind of damage it in the reverse order. The bone under the joint is damaged, which eventually leads to collapse of or damage of the surface cartilage. Again, it kind of ends up with the same result, but it gets there in a different way. And then abnormal development of the joint. If a joint is not shaped the same as average, there can be extra pressure on it earlier than would occur normally, and people can wear their joints out faster than average or at a younger age than average. What's the cure? Well, unfortunately, there are lots of treatments for arthritis, but there is no cure. The cure will finally come when we can figure out how to either regrow cartilage or turn off degradation of cartilage. And for most forms of arthritis, we haven't figured out how to do that. For some of the inflammatory arthritis, there are medications that can change the process but not stop them yet. And that's a very specific small subset of patients. So there are lots of treatments, there are no cure. All of the treatments either fall into one of two categories. Either put less pressure on the worn surfaces or treat the pain and inflammation, or both. How do we put less pressure on the worn surfaces? Believe it or not, the only scientifically proven in studies, way to slow down the progression of arthritis is lose weight. If people have weight to lose, losing weight has been proven to slow the process. Everything else can definitely help, but hasn't been shown to change the natural history, or basically change the eventual outcome of the problem. So not everybody has weight to lose. How else do we take weight off of the joint? Low impact exercise and building the muscles around the joint can actually put less pressure on the joint surface. Assistive devices, canes, crutches, walkers, basically things that put less weight on the joint. Braces fall into that category by shifting around or supporting joints, especially knees. And bear with me, there we go. The other category of treatment is to treat the pain and inflammation. So over-the-counter medications like Tylenol, non-steroidal anti-inflammatory medications, which is what that acronym is, NSAIDs, so medications like Aleve and Motrin. There are topical versions of those. There are supplements that are not technically medications but can help, like glucosamine and turmeric, ice and heat, compression, injections, and there's a couple different kinds of injections that we give, and low impact exercise, which not only helps with strengthening the joint, but also helps flush the fluid through the joint a little bit better. All of those have been shown to help to varying degrees. When all else fails, back into the category of take less pressure off the joint is surgery. Most of the surgeries that we do for arthritis are joint replacement or arthroplasty surgeries. I mentioned these other two for completeness. Arthroscopy has a very limited role in treating arthritis. Arthroscopy is a small surgery putting a small camera and working remotely in a joint. It's mostly done for repairing tendon injuries, like in rotator cuff surgery for shoulders, for taking care of meniscus injuries, for fixing ACLs and knees. It has a very limited role in arthritis for removing mechanical blockages or removing loose bodies or bone spurs that have become separated and are floating around in the joint. Other than that, really is not something we do routinely for arthritis. Osteotomy is just a fancy term that means cutting and reshaping a bone. It is possible if someone has a worn joint in one very specific spot to reshape the bone and put pressure on the less worn spot, classically in a knee, but also occasionally in a hip. But again, that has a very limited role compared to joint replacement surgeries. Joint replacement surgeries fall into a few categories: partial knee replacements, complete knee replacements, partial hip replacements, which are really only done for fractures, complete hip replacements. And on the very end there, I mentioned hip resurfacing. It's just a specific version of pieces and parts for hip replacement. Historically, joint replacements were a 2 to 3 hour surgery. Even when I started residency, which wasn't all that long ago. This was a few-hour surgery, pretty much 100% of the time general anesthesia, drains left in the joints for several days after surgery, a catheter in the bladder for days after surgery, big bulky dressings, even occasionally casts for knees. Patients were on bed rest, either ordered by the doctor or out of necessity because the surgeries were a much bigger deal than they are now. That's not to say that we take surgery lightly, and every surgery is a big deal, but they were more of an ordeal. People would spend on average a week in the hospital and often were very limited in their weight bearing on purpose or non-weight bearing to allow for healing of pieces and parts and soft tissues. Current surgery, most of us that do this surgery regularly use part of all of these more modern concepts. Surgery is much faster, much more efficient. We're not in a hurry, but we're trying to get it done with less time under anesthesia, less time with incisions open. Regional and spinal anesthesia has become the standard of care for joint replacements. So spinal anesthetic, and in the case of a knee replacement, what's called a nerve blocker, putting numbing medicine near the main nerves in the front of the leg to help with pain and relief after surgery. It's been shown to have all kinds of advantages: less pain, less bleeding, less risk of blood clots. So it's pretty much the way we do it, preferably. Immediate or accelerated rehabilitation protocols, full weight bearing most of the time with some rare exceptions. And because of the smaller, faster surgeries, because of some current medications that we give that limit bleeding, we don't typically use drains in joints anymore, which were to drain blood out of the joint afterwards. And because of the quicker surgery, most people don't need a catheter in their bladder. This is now considered by most surgeons and most insurance, including Medicare, to be an outpatient surgery for most patients. Outpatient in Medicare, for example's opinion, means less than 24 hours, not necessarily home the same day, although some patients do go home the same day. Minimally invasive has been a little bit of a controversial term in the past. What does it mean? Is it correct? Is it not correct? Minimally invasive to me and to most of us in this field now means slight differences in implants, so smaller implants that are easier to put in through smaller incisions. Differences in surgical technique, smaller incisions, less disruption of tissues. For example, we don't dislocate the kneecap, we don't dislocate the knee anymore, which were traditionally done in knee replacement. But just as important as the differences in surgery are the differences in how we take care of people before, after, and during surgery. Differences with anesthesia that I mentioned, pain management, rehabilitation, different dressings even. When I started residency, patients had basically a dressing that was just one step short of a full leg cast, and now we put small light dressings that are the equivalent of a large Band-Aid on after surgery. They are less restrictive. They help people to move more and faster because we're not restricting them. Total knee replacements, really, if they let me name the surgery, I would name it differently. I would call it a knee resurfacing because I think that's a better description of what we're actually doing. People all the time tell me they have the impression that a knee replacement is to get rid of everything between the end of the thigh bone and the top of the shin bone and replace it all. Replace the bones, the ligaments, the tendons, everything. And that's not really what the surgery is. The surgery resurfaces the end of the thigh bone, the top of the shin bone, and in most cases, the back of the kneecap. The implant materials are all very similar from one manufacturer and one specific model of knee replacement to the next, because the only ones that are approved in the US by the FDA, there are some rare exceptions in other countries, are a metal implant on the end of the thigh bone, and typically that's a stainless steel alloy with some rare exceptions for metal allergies, with either a titanium or a stainless steel part on the back of the shin bone, and then the bearing in between is typically plastic. Occasionally the entire shin bone part is plastic, so the bearing, I guess, is always plastic. And the back of the kneecap, the bearing or resurfacing is plastic. Ceramics and other coatings are used on occasion. Some other alloys of metals are used on occasion, mostly for metal allergies. So I think it's really important to know these surgeries typically preserve most of the bones, most of the ligaments, with the exception routinely of the ACL, because all of these are designed to mechanically replace the ACL, and tendons and nerves and muscles and all the important structures are still one's own. Hip replacement, very similarly, is a resurfacing. There's an anchor or a stem that goes in the top of the thigh bone that is simply a place to anchor a new ball or a new surface. There's a modular cup. It's a shell. It's a half of a sphere that goes into the socket, and then a new bearing that goes into that. There is a little bit more variation in terms of the materials that are approved and used in the United States. The bearings can be a metal ball with a plastic bearing, a ceramic ball with a plastic bearing, which I would argue is the current standard, and that's what I use the majority of the time. There is such a thing as a metal ball and a metal bearing, which has some unique risks and really has gone by the wayside worldwide, with some extremely rare exceptions. The gold standard, so to speak, for knee replacement for a worn-out knee is to replace all three parts of the knee. The medial or inside compartment of the knee, the lateral or outside compartment of the knee, and the behind the kneecap or patellofemoral compartment of the knee. There are partial knee replacements. They are the least invasive surgery, and there are replacements for all three of those compartments. I think that partial knee replacements are great for a subset of patients. First of all, and foremost, only one of those three compartments can be worn out. If two or more are worn out, it's really not an option. It is a smaller surgery. It is a little faster. It has historically always been an outpatient surgery. It preserves both ligaments in the center of the knee, the ACL and PCL. It is a great surgery when someone's a candidate. Technically, they have to have fairly normal range of motion, a knee that's not very or at all out of alignment, and then really only worn out in one spot. Even then, there are some differences, and the disadvantage is the rest of the knee can still wear out. The main reason people end up having to have a partial change to a complete is wearing out of the remaining two parts of the knee. So these are some of the things that are different, and some of the advantages. It is a smaller, faster surgery. In hip replacements, there is such thing as a partial hip replacement, and I mention that because I always get the question, but that's really only done for hip fractures, where people break the ball off of the end of the bone. If someone has wear of the ball and socket, we can't just replace the ball and expect them to get pain relief. We replace the ball and socket. So partials are really only for broken hips. Minimally invasive knee surgery. This slide is kind of an old one, but I think still worth seeing. The lines drawn on the little cartoon show the red line is kind of the historical, what knee replacement incisions all used to look like. And the blue and the dashed lines are just kind of what most of us do now. Even surgeons who weren't quick to adopt less invasive surgery, just with modern techniques, all of our incisions tend to be a little bit smaller. The scar is really not what is the most important part of it, though. It's what we do underneath. We, as I mentioned, do less dislocating of joints and moving around of bones, and basically just hopefully do less trauma to the knee to do the same surgery. Historically, it has been a little bit more difficult. Most people are learning to do it this way currently. So I would argue that most people coming out of training today are learning how to do it this way, so it's not more difficult for them because it's the only way they've ever done it. Here's just a close-up of some of the different ways to go into the knee. This one I think is important really just to show that single line that shows lateral. For partial knee replacements where just that part of the knee is worn out, it is possible, and I would argue an advantage, to go in the opposite side of the knee. All of the other versions of knee replacements historically and traditionally go through that side where there's a bunch more lines. And there's a bunch of different ways to do it, but they're all a version of similar things. It is something that has evolved. Basically, surgeons discovered that they could sneak, so to speak, these parts in through a little bit smaller incision. The traditional way to do a hip replacement, which was the first major joint replacement to be invented, was about a 2-foot long incision, and they went through the thigh bone and cut the top of it off and put it back on at the end. So we quickly discovered that if we could do less than that, people got better faster. It has evolved definitely just in the time frame that I've been in practice, and I think we really have gotten it to the point where it's, again, I think most people are using some or all of these concepts, and it's pretty much become the standard. Although I would guess there are still surgeons out there that are a little more traditional, so to speak, and probably don't do all of these things. A key on this slide is that it uses traditional implants. Joint replacement surgeries have been around for a long time. They've been refined continuously, and it's important to use implants that have been proven and have a track record and have been around. So all of these concepts, keep that in mind. There are no completely different 180 degrees in the opposite direction pieces and parts that are used. It's just we've figured out how to put the ones that we have in better ways. Hip replacements, there's a little more controversy, there's a little more variation in how they can be done. And I have this discussion every day. Basically, as I mentioned, the traditional hip replacement was a very large incision, extremely invasive, take the top of the femur bone off, put it back on at the end. Very quickly after that surgery was invented, it evolved into sneak either behind the bone or in front of the bone. So an anterior approach goes in front of the thigh bone, a posterior approach goes behind. You can see on this cartoon that really the incisions in either case are kind of on the side. They're just in front of the thigh bone, just behind. Some people have the impression that we're way in the front around towards someone's groin, or we're way in the back around their backside, and we really aren't. There's been a lot of research, a lot of debate about what is the best way to do a hip replacement. I would argue there is no one the best way. There are a couple that seem to have shaken out to have the most advantages and the least risk. And we'll talk more about that in a minute. No matter how a hip replacement is done, the concepts are kind of the same as what I talked about with knee replacements. Smaller, faster surgery, quicker rehabilitation protocols, quicker to get people up and around and on their feet. These are just a list of a few of the different ways to do hip replacements, and it's dozens and dozens of variations, but they're all basically in front of the bone, behind the bone, still in some very rare circumstances, mostly redo joint replacements through the bone. Again, just like knee replacements, it's important to use proven implants that have a good track record and work well. And again, very much like knee replacements, surgery is only one small part of the difference. We've changed all of the other protocols. Traditionally, for example, as part of this list, I mentioned the GI tract. We used mostly opioid type of medications. Morphine is the most classical, and when people just get morphine for pain medication, they have just the side effects from it, specifically constipation and stomach upset and all of those things. All of our protocols now involve some sort of multimodal pain management, and that's the buzz term in medicine for we use different medications. They work differently, they have different side effects, so we don't get any one medication where we get all of the side effects, hopefully, and that's really the goal and the thought. So we typically use a combination of non-narcotic medications, narcotic medications, in bold there because it's our preference, spinal anesthesia, nerve blocks, occasionally We inject medications into the actual joint, and that's the last two that I mentioned on this list, where we talk about local anesthetics like Novocaine and Novocaine type medications that can be injected directly in the joint or in the incision, and even steroids, either injected directly or given intravenously to decrease inflammation during and after surgery. Long-acting nerve blocks are really extremely helpful, and I think have been a big change in our protocols for knee replacements. We've gotten away from the indwelling catheters, where we actually leave a little tube either in the thigh or in the back after surgery, because they just add one more thing that tethers people and holds them back and have some risks, but they can be used pretty effectively. Ice is still something that is extremely helpful for all of orthopedic surgeries, and definitely for joint replacements. It's a great anti-inflammatory. It causes a little bit of pain relief or numbing at the site, and it's something that we utilize extensively still. We try to address everything, not just the pain, but the side effects from the pain, the side effects from anesthesia. We do lots of things to try to prevent those and limit them. Hydration has been something that traditionally we weren't as good at, and people got very dehydrated before surgery because of not eating and drinking, and during surgery, so we're very aware of that. Inflammation is something that is our enemy. Inflammation is part of pain, it's part of swelling, it's part of decreasing and inhibiting range of motion, so we do lots of things to minimize that. Changes in the surgery, steroids, anti-inflammatories that are not steroids, all of those are really important. Physical therapy. Basically, the change has been hurry up and wait to go, 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 go. Whether we're talking about hips or knees, it's up and moving as quickly as possible and home as quickly as possible. Not that we're trying to rush people out the door, but we want people to regain function as quickly as they can. We want people to regain normalcy as quickly as they can. We want people to sleep in their own bed that they're comfortable with because they feel better faster. So with hips, it's immediate weight bearing. It's canes, crutches, walkers for balance and comfort, but not purposely staying off of it. And it's rid of those things as soon as people are up to it. Some people it's days, other people it's months. It depends on how much trouble they're having ahead of time. It depends on how quickly they recover, and everybody's a little bit different. Some of it is predictable based on people's age and how bad their joints are. Some of it is a little bit unpredictable. So we kind of go at that individual patient's pace. For a knee replacement, in addition to go, 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 it's bend, bend, bend. The best way I ever heard it described with a knee replacement is it's a race between forming the scar tissue in the knee and getting the bend. Traditionally, when knee replacements were invented, people were immobilized in a cast, and they got so stiff that their knee never functioned again. So they very quickly realized we should do the opposite. And we have been going more in the opposite direction all the time. And now we quite literally put the stitches in at the end of the surgery with the knee bent. So we're not, hopefully, inhibiting bend from stitches feeling tight. So we really concentrate on as much as we can, as fast as we can with the bend. Hips. I always have a discussion with people. I often get the question about what can I do, what can I not do after hip replacements. Traditionally, all hip replacements are some version of opening the joint and taking the ball out of the socket or dislocating the joint. We now, with modern surgical techniques, put the ball back in and close the joint. They, believe it or not, used to leave it open or actually take the lining out. So the risk of dislocating the joint has decreased significantly. Most studies show that it's less than 1%, but there is still a small risk. So unlike historically where most surgeons had people follow very strict rules for the rest of their life about not moving certain ways, we have people avoid certain positions that are risky for about 3 months after surgery, a minimum of 6 weeks and a maximum of 12 weeks. The surgery has changed in that we put everything back at the end, specifically the lining the joint. Also, the surgery has changed in that the ball that we put in has become significantly larger. When hip replacements were invented, the diameter of the ball was 22 millimeters, And now most of them are 36 millimeters or more. And that was done for wear and tear or wear of the bearing. There are some advantages mechanically to a smaller ball, and we've fixed the need to use a smaller ball. So currently, the thinking is the bigger the better. We also are involving people more in their surgery. It's no longer, here's what you need done and we're going to do it to you. See you next Thursday. It's, here's what you're a candidate for. Here's what's involved. We're going to get through the process with you if it's something you choose to do. Countless studies have shown patients do better, feel better about their surgery, have better outcomes if they're more involved. Certainly there are still people who don't want to know the nitty-gritty details, and we can accommodate that, and there are people that want to learn how to do the surgery, and we'll show you, but we won't let you do it. There's been a huge shift in elective surgeries, not just joint replacements, from the sick patient model to the well patient model. We're basically realizing that we are doing a procedure for a patient who has a bad hip or has a bad knee, or in the case of a shoulder replacement or an ankle replacement, has a bad shoulder or ankle, but the rest of that patient, there's no reason for them to be in the hospital. So we're not treating them the same as we are the person who's in the hospital for pneumonia or for a bowel obstruction or something else, because they're very different things. Who is the ideal candidate for minimally invasive surgery? I would argue that everyone is. It is minimal for them. So the incision, the invasion on the body, the time spent in the hospital, the downtime in general is less for that patient than it would be otherwise. People who have had these done a long time ago tend to notice a big difference. People who have never had one still tell me it's a pretty big deal because it's the only one they've ever had. So it's definitely a better surgery and it has evolved, but it's still a joint replacement. It's still the biggest one they've had if it's the only one they've had. Minimally invasive, I try really hard, as I think you've heard, to not focus on incision size. It's a lot of things in addition to that, but also it's minimal for them. If someone's 6'5" and 300 pounds and played in the NFL, the incision's bigger for them than the person who's 5'2" and weighs 110. So it does have to do with the size of the patient. Their bones are simply bigger. To put in the right size parts for someone who has bigger bones, we have to make a little bit bigger opening. The severity of disease. There are rare occasions where people have so much bone loss and they have such badly deteriorated joints that it is a little bit different surgery. We're putting in bigger parts. We're doing a little bit longer surgery, and we're maybe making a little bit bigger incision to put in those bigger parts, but those are unusual circumstances. Condition of the skin. There used to be a lot more argument about really pushing the surgical incision size to an extreme in terms of how small it is. We really have learned with this surgery, it's not about incision size, it's about all the other things. So we don't hesitate to make a little bit bigger incision if it's a little easier on the skin and creates less tugging and less damage. And then people's recovery, I can't stress this enough because people all the time will compare themselves to a friend, a neighbor, someone who's had it done, or even to themselves 20 years ago when they had another joint replacement, and they'll say, boy, I really just, I didn't get as well as quickly as somebody else did, or as quickly as I did 20 years ago. It really has to do with how are they at this time, or at the time that we do the joint replacement, and everyone's a little bit different, and every time is a little bit different. Even if we do 2 joint replacements on the same person separated by a year, the recovery one time to the next is not always exactly the same. So what are the benefits of this? Well, less trauma, so hopefully less pain, faster recovery, less bleeding. There is definitely far lower risk of needing a blood transfusion with an elective joint replacement nowadays. The risk used to be on the order of 5% or more, and blood transfusions are not an insignificant thing. There's a risk of transfusion reaction and allergic reaction, which can be life-threatening. Interestingly, with joint replacements, getting a blood transfusion, even if it's getting someone's own blood back who's donated it ahead of time, causes a slight increased risk for infection. So the smaller, faster surgery, along with one medication that we now routinely give called tranexamic acid, which decreases the bleeding at the surgical site, and we borrowed from the cardiac surgeons. Between those two changes, we've been able to get the blood transfusion risk to virtually zero. Less pain, not as important to the recovery and to the function, but the scars are smaller and they're harder to find and see. Shorter hospital stays. This is now an overnight and even home the same day surgery. And hopefully a quicker return to someone's life. That whole point of this surgery is get people back to doing the things they want to do or need to do without their hip or their knee getting in the way. And hopefully these techniques and these concepts get people back to that faster. What are the potential complications and risks? They're not really unique to minimally invasive or less invasive surgery. They are mostly related to just the surgery, but historically, a little tougher on the skin if we take it to extremes. There was a trend towards not putting in parts as well. We've, I think, gotten past that as a profession. And there are things that affect how small or how big the surgery is, how comfortable the surgeon is with doing it their particular way, and there are a bunch of right ways to do it. They're all variations on a theme. They are all as correct, I would argue. The size of the patient, how able or willing the patient is to participate. Knee replacements are a very active recovery. The therapy and the patient's part of it is as important as the surgeon's part of it. Hip replacements are a little more passive recovery. Yes, we have people do therapy. Yes, it can be helpful. In studies, it's been shown to not be as essential or critical. Previous surgeries. We do, or I do, use a lot of these same concepts for redo surgeries. I will often, when I have to do a redo, end up making a smaller incision and do less surgery than was done the first time, especially if it was done a long time ago. But it's not for every revision. It's not for every difficult surgery. It's certainly not for the third or fourth or fifth time surgery, which hopefully most people are not having, but some people do for various reasons. It's still evolving, not just minimally invasive surgery, but joint replacement surgery. It's continuously been refined since it was invented for hip replacements in the 60s, for knee replacements in the 70s. And we're constantly studying and trying to make it better. It might be enhanced with computer-assisted or even now robotically assisted surgery, but there's no evidence as of right now that either of those are better. Computer-assisted surgery, or lining up the parts with not just mechanical devices, but photo eyes attached to computers and special computer programs, has been around for over a decade. I've used it at various times for very specific reasons when the mechanical devices don't fit into the bones or on the bones. But the current state of research shows that it's equal. So if a surgeon knows how to do it and is good at it, the results are as good but no better than any other way. Same thing with robotics. Currently, we are in what I would think is the first generation of robotic-assisted surgery. It is an extension of the computer-navigated surgery, and it's definitely not the same as abdominal surgery, where robotics has been around for 20 years. It's been refined. There is definitely some evidence for superiority. The hospital here in Jackson does have abdominal robotic surgery. We have the capability to do robotic-assisted joint replacements. I'm not using it because I'm a real kind of by-the-book, evidence-based surgeon. I kind of figure if it's adding even a minute to surgery or adding even a fraction of percentage of risk, I'm not going to do it until we're showing that we're adding a percentage of increased range of motion, or we're adding a fraction of a percent more of success rate, and currently we're just not. So now I'm going to let Jamie talk specifically about our program here at St. John's and what she's evolved, as she said, over more than a decade.
Thanks, and we're so pleased to have Dr. Lighthart as part of our team. He's been a great addition. Thank you for coming to Jackson Hole and joining us. Just want to talk a little bit about our program, what makes it different. We know that having a joint replacement is an elective procedure. You have the choice, and we realize that, to go wherever you want. Do you want to go to Mayo Clinic or Hospital for Special Surgery, or do you want to stay here local and have your care here? So why should you choose to stay here? That, I guess, is really the question. The goal here is to create an experience that is repeatable every single time for every patient. It's taken a lot of time and a lot of work to get it there, but I think we're really proud of the care we provide. The way I look at it, it's specialized care for you. It's personal. I'm involved with every single patient that comes through for a joint replacement. I get to know you ahead of time. I teach you. I follow you through the stay. I check in on you before you even come in for surgery. Make sure you have a good plan going home. I'm available for you kind of 24/7 after surgery if you want to give me a call. But really, it's that personalized care that I think makes it so much better to stay local. Plus, there's great surgeons no matter where, and we live in a great town with great orthopedic surgeons that choose to live in Jackson Hole, so we definitely have that added benefit. Many of the stuff that's on your screen, Dr. Lighthart really already talked about. What are the things we streamlined? Well, protocols, order sets. At the time we started the program, we had 3 surgeons doing joint replacement. Getting them all on the same page and doing the same thing was difficult in the beginning. It's helpful now because we only have 1 to work with and convince of things we want to change or do. Pain management, as Dr. Lighthart said, has evolved significantly from being on buttons and what we called PCA machines, where you're giving yourself doses of morphine all day, knocked out from the narcotics. Now, with the addition of spinals and nerve blocks, people are mostly taking Tylenol and anti-inflammatory and a little small amount of narcotic, and for a short period of time. So definitely some advantages there. Blood transfusion, I think he covered well. Lots of things we do for infection prevention. Some things that you don't see normally, maybe. We do MRSA screenings ahead of time, so we check you to see if you carry staph, which is an added risk for infection. If you do carry those germs, we pre-treat you prior to surgery to decrease your risk. Special suits the doctors wear in the operating room to keep them from sweating around their surgical masks. Lots of little things that you never would even know that are just added ways of preventing infection for you. Another thing that I think is key is our staff loves what they do. So we have, key staff that have chosen orthopedics. They've chosen to take care of our joint replacement patients and our spine patients. They've decided to do extra training to learn more about orthopedics. They do it over and over, which makes them, experienced and specialized and able to repeat that experience for every patient. We're really into, group activities when we can, do them around COVID times. But we have rooms reserved just for our joint patients. We have recliner chairs so they can be up and active, not just laying in a bed feeling like a sick hospital patient. We have a physical therapy room that is just for our joint replacement patients, where they go for exercises and education and stair training. But as Dr. Lighthart said, education to me is key. I teach classes every week. Patients come in to learn what to expect prior to surgery, what's the recovery like, what's the stay in the hospital like. And while every patient sits down in that room when I start the class and looks at me like, really? Why am I here? I don't want to be here. I have to take a class to have a surgery. By the time they leave, almost every single one of them tells me they learned something, they feel more confident, and the goal is really to have a successful outcome and prepare you up front on what you're getting into, know how to set up your house, what kind of appointments you need, what the therapy consists of, and really teaching you up front before you get the narcotics and the anesthesia and can maybe actually remember something. Also very important to us to include whoever's going to help you at home. It's not always a family member, so we call that person your coach. But we like them involved in preoperative education, so learning the same things you do before you come in. Being involved after surgery in the hospital, going to physical therapy with you, learning your exercises so they can, cheer you on at home as you do them at home. And also, again, if you have anesthesia and pain meds, you don't remember anything we tell you while you're in the hospital. So having that key support person there with you to hear the discharge education, learn your medications, see you get up and down and know that they don't have to lift you out of that bed really helps support that role of the person at home and make them feel more comfortable. like Dr. Lighthart said, it's all about wellness, this concept of wellness, getting people moving and back to their lifestyle. So how do we do that? Early mobility is key, getting people up as soon as they're able to feel their legs post-spinal, up and active routine. One thing we didn't, I guess, talk about a lot is making sure our patients come in, I guess he did talk about it some, but come in with medical clearance, meaning all their medical problems are optimized as well as they can be. Their diabetes, their, blood pressure, all that stuff is under control, so we're not adding the stress of surgery and increasing risk for complications. So we do require all our patients to see their primary care provider ahead of time and make sure their medical issues are under control. While you're in the hospital, we treat you like a well patient. I don't know how many of you have had surgery, but the minute you put on that gown and sit in that bed, you feel ill. It's just uncomfortable. The gowns are uncomfortable, your butt's hanging out. So we like to treat people like real people, right? After surgery, you can put your own clothes on and feel comfortable in your own things. Be up in the recliner versus laying in the bed staring at the clock. The concept of getting people out and going to therapy, getting out of your room makes you feel well. You're working towards your recovery, you're interacting with other people. There's a sense of camaraderie and people helping each other and cheering each other on. So we really like that added effect of having other people around experiencing the same thing together. We have a little board in the hallway that's just called Reach Your Peak. It's a magnetic board of the Tetons. We really encourage getting distances of walking in. Cumulatively, 2,000 feet gets you to the top of the Grand before you go home. So you can have a little race down the board to get to the top of the Teton first if you're someone that strives off competition. And one thing I think that it is important to me is the relationship doesn't go away when you go home. Most places you have surgery and they say, see ya. And of course, it's always that way a little bit, right? But I always leave, a line open for the patients if they have questions, concerns, something they don't want to call the doctor about. I'm happy to take those phone calls. I want to decrease stress for people, get their anxiety to, be lower. So I give out my phone number, whether that's a good or bad thing. Usually it's good. I call people after they go home, making sure they're settled in at home. They understand their medications and how they're supposed to be using them, just making sure they're smoothly transitioning to the home environment. And hopefully someday we can get back to the fun group luncheons we used to have. I'm still crossing my fingers that COVID isn't going to exist at some point in time and we can get back to socializing. But pre-COVID, we did reunion luncheons. And again, hopefully someday we will do that again. But it's an opportunity for us to hear back from our patients, not just in a survey that you get in the mail or over the email. It's a personalized way of people sharing their experience, learning from them. What was helpful for you? What education was missing? What should we be telling every patient that's coming in for a joint replacement? What do they need to know? So I feel like that was a really key part, and hopefully we can get back to that someday. Ultimately, the goal is happy patients and positive outcomes. How do we get there? I'd like to share some of what we're doing now and what our outcomes look like. Statistically, looking back at the prior year or two, 90% of our patients are considered outpatient procedures, meaning they stayed one night or less in the hospital. Some of those, yes, went home same day. Only about 10% of patients actually need more than one night stay in the hospital. And that's really determined on how they're doing postoperatively and if they need continuing assistance. 95% of our patients have gone directly to their home, maybe with home health or directly to outpatient physical therapy, but really only 5% of patients have actually qualified or needed to stay at an inpatient facility after surgery. And again, happy patients, that's the goal, right? Looking at patient satisfaction, just something to brag about, I guess. But 97% of people said they would recommend us at a 9 or 10 out of 10. I got to put a shout out for our physical therapists, getting people up and moving quickly, getting their knees moving. On average, our patients' knees are bending up to 102 degrees before they even leave the hospital, which is pretty impressive. Everyone's up and walking, at least most people, hopefully 300 feet the day of surgery. We try to do a big long walk the next morning before going home, sometimes even up to 1,000 feet. So trying to get those community walking distances in so that when you get out there, you can actually do that. You need to walk more than 20 feet to live your life, so that's our goal. On your screen, just some fun patient testimonials of patients that have been happy over the years, and that's our goal, getting people back to their life. And I'm sure that's your goal too, so we'd love to help you if you're interested or needing a joint replacement. I think that's about all we have as far as slides are concerned. But we did get a lot of questions that were sent in when you registered, and like to go over and just do a question and answer with Dr. Lighthart, and hopefully answer the questions that you were most interested in.
Thanks, Jamie. I also wanted to add something to what you said. I've been here 7 months. It's been an absolute pleasure to walk into a place that had a program in place that was as developed, as outstanding as this, really aligned with what I have been trying to do and have done elsewhere. To your point, why should someone stay here? Why should someone even come here from somewhere else? It is what we do. It's what we do. It's what we do well. We do a lot of. What I told patients where I came from, because it was a similar setting, and what I definitely tell people here is, we don't do heart surgery, we don't do brain surgery, we do joint replacements and orthopedic surgery. We do a lot of it, and I'm spoiled because we do it well. We have the latest, greatest technology. I have the best parts and implants, the best materials, the best operating room table, the best equipment, the best imaging with MRIs and CT scans and anything we could ever need. And orthopedics is kind of the top dog when it comes to a lot of that. There are definitely places where people can get surgeons that are as specialized, as highly trained, as experienced, but I don't think they can get the rest of it necessarily somewhere else. And I'm also a very big believer in go as close to home as you can. If you don't have to travel, don't, for the what ifs. What if you need to talk to you after surgery? What if they need to come see me after surgery? It's really hard and sometimes dangerous to get in a car and drive hundreds of miles to go see your provider if you need to. Occasionally we need to do that. I think this is one case where we definitely don't, and we might have some advantages compared to some other places.
Yeah, well, thank you. Always that looming question, how long does a joint replacement last?
That is the number one question that I get, or should be one of the number one questions. Historically, and that's really what we have to go on, looking at big studies, joint registries, we had about a 90-some% survivorship at 20 years. What does that mean? It means that 92%, for example, if you look at one particular registry or study of knee replacements that were done, still were functioning and in place and hadn't worn out or hadn't needed to be redone in 20 years. And that number of replacements that were still intact got smaller and smaller after that. Very similar numbers for hip replacements. The current technology is better. The lab testing, where they simulate wear over shorter periods of time than decades, shows that the materials are better. They should last longer, but we're really guessing until we've looked at those particular implants for 20 to 30 years. So my best guess is that most patients will get 30 years out of it, so 90+% of patients, but it's really just an educated guess. It's more the number of miles than the number of years. It's like tires on your car. The more miles a year you put on it, the more impact and weight you put on it, the faster it wears out, presumably, and there is some evidence to show that. So historically, there was a list of things that people couldn't do after joint replacements, and I had to memorize it when I was a resident. It really was a list that someone came up with, and it was their opinion of things that you shouldn't do. But the general concept is the more wear and tear you put on it and the faster or more miles a year, the faster it will wear out. They are mechanical parts, and it's just sort of something that is the nature of mechanical parts.
Yeah. Are there any activities you would advise patients not to do?
I tell patients that they should be aware of the fact that running or endurance sports, ultramarathons, marathons, triathlons really do put a lot more wear on the parts a lot faster, but I've had patients that do those things, and they simply tell me, I'm aware of that, I realize it, I know I might be getting a little less time out of it, but that's okay. And then I have other people that I actually try to encourage to do more because they have either heard or come across the old-fashioned thinking and a very restrictive list of things you couldn't do, which is, I feel, outdated.
Okay. And speaking of a joint wearing out, what normally would wear out?
The bearing is what wears out. So in the case of most joint replacements, it's the plastic. It's a very specialized plastic is what I tell people. It's highly cross-linked, it's antioxidant infused, highly cross-linked polyethylene, but it's really a specialized plastic. The wear characteristics of what we currently use are way better. It's actually hard to even measure wear in 10 years, which we used to be able to do pretty easily with some sophisticated CAT scans, but it's still plastic. So that's what wears out. And that can cause some unique problems with the bone. Ultimately, if there's enough wear, it can actually cause the parts to come loose from the bone.
Okay, so and for the patients that are already out there that have had their joint replacements, how often should they be seeing the doctor, and what signs should they be looking for that might be of concern?
The answer to that question kind of spans the spectrum and depends on the doctor. Some say, come back if you ever have a problem. Others say, I need to see you every year. And I kind of fall in the middle. I recommend, based on the little bit of research we have looking at this, and then also a little bit based on my own opinion, x-rays routinely every 3 years. The comeback every year really tends to be surgeons that are doing research projects and need to have x-rays every year. The don't come back ever, it relies on the fact that typically people will have some pain or some swelling, or they'll get a little bit of mechanical difference with their joint when there's enough wear. But I feel there's a large enough subset of patients where we can see the trend towards wear over time by taking x-rays over a very long time routinely, that we can catch things a little sooner than later. And I'm a real kind of better safe than sorry type of doctor. So I do recommend every 3 years. If someone's 97, it's probably okay to just come back if you need to. If someone's 45, it's really important to come back every 3 years, and everyone else is somewhere in between.
And am I right to assume that you're happy to follow up any patient, whether they've had their surgery here or anywhere else in the country?
Absolutely. I have met lots of nice people that have had joint replacements done by other people or other places, and I'm happy to take those over all the time. I tell my patients they're stuck with me or another orthopedic doctor for good, because I do recommend those routine follow-ups.
Excellent. One question that comes up a lot, I have I have knee pain. I'm just messing it all up. My knee hurts, but I've been told my hip is bad. Can hip pain cause knee pain?
That is a very common question. It is a very common pitfall, especially for non-orthopedic doctors. And then especially for patients who shouldn't necessarily know the answer to that question. But it is very common for hip pain to be referred to the knee. It is actually not terribly uncommon. There's a small subset of patients who really have a bad hip and only have knee pain, which is where it can be confusing. But the opposite typically doesn't occur. People really don't, because of the way we're wired as far as our nerves, have pain referred from the knee to the hip. They certainly can have their gait thrown off and have a limp or move differently and be sore in other places, but the phenomenon with knee pain from the hip is actually directly referred and transmitted through the nerves.
One question that didn't get asked here, but I get asked all the time, how do you know when it's time for that joint replacement?
I tell people it's not my job ever to tell someone you need a joint replacement. It's my job to tell them you're a candidate for a joint replacement. Here's why you're a candidate, which is typically you've failed all those other treatments that we talked about earlier. Here's what's involved: the risk, the recovery, the downtime, and actually there's a lot more to it even than we talked about, as you know. And you'll tell me or tell someone else when and if you ever need it. Typically, it is when it is impacting their life enough to be worth all of those things. Some people will push me a little further and say, well, okay, but when do I know? And classically, it's when it's affecting their daily activities, things they have to do, not just want to do. So they hesitate to walk upstairs to get something because they know it'll hurt. They avoid going to the store. They skip things simply because they know they'll cause pain. And then another big milestone that people will reach is they have pain at night. They have trouble sleeping because their joint hurts. Those are two big things that will drive people to make that decision, but everybody's threshold is different. Some people would rather never have surgery and just deal with it for good, and that's okay. It's not necessarily the best option, but it's an okay option. And some people are a little too quick to investigate joint replacements, and they don't sometimes realize that we have some other options short of that.
And what kind of things should you try before you get to that joint replacement?
I'm a big believer in try anything and everything short of surgery that was outlined in our slides earlier that someone is willing or able to try. Not everybody is a candidate for every one of those treatments, but most people are candidates at least for some, if not all of them. So typically, for example, injections in the knee, and there's 3 general classes of injections: steroids or cortisone type injections, visco supplementation or artificial joint fluid injections, and PRP or platelet-rich plasma injections. They've all been shown to work to some degree. They've all been shown to be temporary, but temporary can sometimes be useful. Temporary can get someone past a vacation or something coming up for work. Temporary can get someone a few more years until they're a little older and a little lower risk to ever wear the parts out in their lifetime. So those injections often are a good option for knees. Studies show that most patients get some relief for several years at least, and then they stop working. We all have patients in our practice where they've worked kind of for good. I had people where I came from that I left and I'd been giving them injections for 10 plus years and they were still working. Because of that subset of people where we just can't predict who they're going to kind of work for good, I don't usually recommend jumping right to surgery. Hips, we have less options. Shots work less well, sometimes don't work at all. But all of those other measures can help to various degrees, taking weight off the joint, treating the pain and inflammation in ways other than injections. Occasionally, injections are appropriate for hips.
And what's the rehabilitation like recovering from a hip or knee replacement? How long does it take? What can you do at 3 months, 6 months, a year?
Even with all the advances that we talked about, I still tell people the way that I would sum this surgery up is it's about an hour-long surgery, usually less when we do it, but with a year-long recovery. People have some milestones. I tell patients, whether we're talking about a hip or a knee or a partial knee, it's about 3 months to be 85 or 90% recovered. With a knee especially, it's a very active recovery. People have to work with physical therapy to get the best possible result. Then it becomes often frustrating for people that next 9 months, that next 10 or 15% is more passive. To regain as much motion as they're going to, the last little bit is just a waiting game for the last pain and inflammation and swelling that lasts a remarkably long time to go away. And biology and time get rid of those, not anything else that we can do. With hips and knees, regaining muscle memory and muscle tone and reversing atrophy of muscles takes a very long time. What I tell people is muscles atrophy in days, they recover in months to years. And just getting as much out of it as they ever are going to takes a remarkably long time. Now, most people will come back to me in a relatively short amount of time at their 4-week visit, for example, and say, oh my gosh, this is already better than it was, but I still have pain, I still have swelling, I still can feel where the surgery was, but I already can see the light at the end of the tunnel where once those things are gone, this is going to be way better than it was. For people to completely forget they've had a joint replacement, this is not just my experience, there was a paper a few years ago, the forgotten joint replacement, is really 2 years. There are some differences, especially with knees, from a normal joint. And for people to recover as fully as they're going to and to get used to those little differences really does take a couple of years.
And the little buzz out there is we have a new inpatient rehab facility. Do many of your patients qualify for that, or how does a patient qualify to go to inpatient rehab?
Most people, as you mentioned in your one slide, don't need that and historically haven't. My grandmother had a knee replacement many, many years ago, and her surgeon's routine, and I did a rotation with him in medical school, was to send every single patient to inpatient rehab, and that was the model, and that was just the norm. We now know that if we don't need it, people feel better, do better, are better faster. It's an amazing resource to have when we need it in those 5% or so of patients. I probably, because I am so specialized, will have more patients who have really drastic problems or need a third-time redo, or have some things that need that rehab facility, and it's an amazing resource when we need it. I've been in it. It is beautiful. It is well equipped. It is well staffed. Fortunately, I would say, we don't need it very often.
Yeah, unfortunately, we don't get those Teton views at the hospital. They get them at rehab. Darn it. So say I've been waiting for that knee replacement for years now, and I finally decided I want to have it done, and I'm going to come see you. What's the time frame on getting scheduled for surgery and having it done?
So right now, because I'm relatively new, I've been here for about 7 months, I have lots of holes in my schedule and opening. As you might imagine, with all these treatments that can help for years and help put off surgery, sometimes it's years of me seeing someone and taking care of them before they ever come to the decision or ever need surgery. So because I haven't been here for years, I have spots in weeks, not months. My practice previously got to the point where it was about a 3-month wait. I have colleagues where it's a 10 or 12-month wait. I have tried really hard in my career and will continue to try really hard to never make it more than about 6 to 12 weeks. When it starts to get to that in my practice, I take more time in the operating room or do some extra surgeries or basically try to catch up, because I don't think it's a great thing once someone gets to that point to have to wait much longer. Now, even if my surgery schedule is completely open and I have nobody scheduled, it does take a few weeks to do all the things that we do to make it safer. You mentioned some of the things that people wouldn't realize. What goes into optimizing the results or decreasing the risks, as you know, is time consuming. It takes a while to do that nasal screening that you talked about. It takes a while to check someone's blood count and to have them go to the class and to have them get the once over from their regular doctor and do all the things that we do to make it as safe as possible. So all of that takes at least a couple weeks to do it quickly, sometimes longer if people need more things done.
And what do you think about bilateral or both joints being replaced at the same time? Is there advantages, disadvantages?
I would say for hips that my opinion is that the only reason to do two at once is if someone truly won't be able to walk on one if we do the other. So for example, if someone's hips are stuck, bent, and we straighten one out and the other foot literally won't touch the floor. So I've done 2 hips at once for that reason. But other than that, because we can't use tourniquets for hip replacement, and even with our faster surgeries and better protocols, the blood loss is less, it still increases the risk of needing a blood transfusion for 2 at once. So I'm not a proponent of 2 hips at once, and most surgeons are not. Knees are a different story. There is definitely some evidence around risk. I always think my job is to do 2 things. It's to do a lot of the same surgery and be very technically proficient at the surgery. It's also to be a good doctor and to minimize risk. So if you look at the data, people over a certain age are higher risk, just even if they're perfectly healthy, having 2 knees done at once. So I have an age cutoff. It is a little bit debatable, one age versus another, and I will tell people about that debate and what those ages are. And then we know some patients are higher risk no matter what the age. Someone who's had 5 stents and has bad cardiac disease is just too high risk for very bad things happening, heart attack, stroke, and death. Everyone else who is young enough, healthy enough, basically falls into the low-risk category. I warn them that 2 knees at once is harder. We lose some of the benefits of the accelerated protocols, but there are definitely folks who that is okay, and they still make it through a little bit harder recovery that is overall shorter compared to doing one, waiting till you're better or most of the way better, and then doing the other. The other little piece of the science for bilateral knee replacements is that you're taking a risk every time you do surgery of infection. Our infection rate should be what mine has been historically because we're doing all the same protocols. Hip and knee replacements in the United States still have a quoted rate of 1 to 2%. I've joined a bunch of other surgeons worldwide with these really strict protocols to get it down to a little less than 0.5%. But interestingly, if you take the chance twice, the statistics are that the overall risk is a little higher compared to once. So if someone is a safe enough candidate for 2 at once, and they're willing and able to go through that, there is a little bit of an advantage in the statistics for infection. Everything else is just about the same, and then for certain people, the risks are higher.
Well, and you talk about higher risk, and obviously there's lots of patients out there that have higher risk. Does that mean they can't have surgery, or what are the steps they need to take to be able to have surgery?
It's very unusual for someone to be too high risk for surgery. There's very set protocols for elective surgery where people smarter than the orthopedic doctors, cardiologists, for example, have come up with a risk stratification system. But in general, people are low risk, medium risk, or too high a risk, to oversimplify it. And it's very unusual that someone is and stays too high a risk. We do catch people with some regularity who have something else going on that they may or may not know about, and, for example, need to get their heart stents first, or they need to get a valve fixed in their heart, or they need to get their diabetes better controlled, or they need to quit smoking. There are things that we can modify that if we modify the risk ahead of time, we get them into that lower risk category. Very occasionally, someone is just so ill that they're too high risk for surgery, but that's pretty unusual, and often people at least suspect that or they're aware of that because it's usually someone who is pretty sick.
And a specific patient question pertaining to that, if you have a history of blood clotting like pulmonary embolism or DVTs, can you still have surgery? Do we do anything differently for those patients?
We worry about a lot of things every time we do this surgery. We worry about infections, we worry about damaging nerves, arteries, blood vessels, all the technical parts that go into doing a safe surgery. We worry about blood clots every single time. Anyone who has an orthopedic injury or an orthopedic surgery is at increased risk for a blood clot. So we do something, even if someone has no history, we do lots of things actually to decrease that risk. We have them wear special stockings during and after surgery. We use some little air pumps on their legs during and after surgery while in the hospital. And everybody gets put on a medication after surgery based on their risk. More powerful blood thinners are used for people who are higher risk, less powerful are used for people who are lower risk, and we stratify people based on, again, the evidence and the science to higher or low risk groups. The absolute highest risk patients are people who have had multiple blood clots or have clotting disorders, and we know that even if they're on blood thinners chronically, they're very high risk, and there is a temporary device that can be put in the main vein in their body going back to their lungs to catch blood clots called an IVC, or inferior vena cava filter. So very rarely, I would say in my practice, once every few years, someone is so high risk that we need to do that. But even those patients, we can do surgery, and we do.
Okay, thanks. And another specific question from a patient, if someone's had a hip resurfacing in the past and they had great relief for years, but now they're having return of pain and decreased mobility, are there options for them? What's the next step?
So I'll answer that question in 2 ways. I would first say a hip resurfacing is a version of a hip replacement. It's specific parts that go in, but it's still a ball and socket replacement. And all versions of hip replacements or knee replacements can have wear and tear, can have some things go wrong with them. And if people do have pain and decreased mobility, they should definitely, even if they're not due for their routine checkup, have that looked at. Unique to hip resurfacings, at least in the United States, is that all of the ones that I know of that were FDA approved, there were some investigational study ones, that were different, but all of them that were FDA approved were metal ball with a metal socket, so a metal on metal bearing. And there are some unique risks to those bearings to the point where, whether it's resurfacing or a more traditional hip replacement part, they've pretty much gone away and aren't used except for some very rare circumstances. So the current recommendations are that anyone with a metal-on-metal bearing should have very routine follow-up at least every 3 years, not just with x-rays, but also with some other testing, specifically MRIs and some metal ion testing looking at metal ions in their blood. There definitely are things that can be done for the overwhelming majority of joint replacements, resurfacings, or otherwise, if they are failing in one way or another. So very specifically with resurfacings, if they're having a reaction to the metal ions, they can be changed to a hip replacement that doesn't have a metal-on-metal bearing. And that, unfortunately, is something that is happening more and more as time goes by, and that particular type of device has been out there longer in more people.
And you talked earlier about activities that are helpful for decreasing arthritic pain and saving the joint, like losing weight, and low-impact exercises. What are exercises that are helpful for someone that's suffering with hip or knee pain? What can they do that's helpful?
The textbook answer is cycling and swimming. They're both great exercise. They both move the joints. They are both not fully weight-bearing or high impact. What I tell people is not everyone's hip or knee reads the textbook. So there is definitely some trial and error. Those are exercises that I always mention. I know for myself, I couldn't swim many laps because I'm just not good at it, but I can ride a bike. So for my arthritic hip, I ride a bike. But cycling, swimming, elliptical machines, low impact walking, yoga, Pilates, anything and everything that doesn't irritate someone's joint is a good thing. I definitely have people that can run a little bit, although historically that's one of the things that we would predict they can't. It's interesting, I have some people that can run on some surfaces and not others, but in general, lower impact, less full weight bearing activities.
Okay. And for those grandmas out there, will they be able, after a hip replacement, to get down on the floor again with their grandkids and crawl and squat and play with them?
Yes, after the initial period of being a little bit careful, and often for patients when I have the discussion and I say, after your hip replacement for 3 months, to be better safe than sorry, you shouldn't put your knee by your opposite ear, they say, I haven't been able to do that in 10 years. So for lots of folks, it's not a restriction at all. For others, it's temporary, and eventually we let people do anything they feel comfortable doing. Interestingly, I get that question all the time with knees as well. Can I kneel? Can I get on the floor? There are 2 parts to the answer to that. You're allowed to, and you won't hurt the pieces and parts, but lots of folks aren't comfortable doing that. They either are too sensitive on the front of the knee where the incision is, and all versions of knee replacement put an incision somewhere on the front of the knee, not the back or sides, or they don't bend enough to feel comfortable. Most of my patients who get enough bend, if they persist and they push through the initial sensitivity, eventually it becomes less sensitive and they are able to do it. So certainly they're allowed, not everybody chooses to do that.
And maybe we'll wrap it up by asking, do you think there's anything promising development-wise for the future of arthritis and treatments?
I think one of those slides I had towards the beginning is what will eventually put me out of business as a joint replacement surgeon, hopefully. I think there will always be people who have worn out their previous joint replacements, or at least certainly in my career, their hips and their knees and other joints are too worn out. But eventually I think we'll have medications to slow down or stop the progression of disease, and or gene therapy to turn back on healing of cartilage. Interestingly, in kids, if they damage their surface cartilage in a joint, it can heal. Once we're done growing, cartilage is done healing, and we're not exactly sure why. There's a tremendous amount of research that has gone on and is going on into those 2 areas. Unfortunately, I don't think we're close yet. I think it might happen in my lifetime, but maybe not in my career.
Guess we'll see what happens, huh? Any other questions you feel like we haven't answered that might be out there?
Again, thanks everyone for bearing with me and listening to this format. Typically, when I give a talk like this, there's an audience and people ask wonderful questions. People are way smarter than me when it comes to this. But I think we covered most of them. If anybody has any other specific questions, feel free to get a hold of me, get a hold of Jamie, go through the folks at the hospital or even at my office, and we can answer them. we do this every day, and we know most of the answers, and if we don't, we'll find out.
And Dr. Lighthart is at Teton Orthopedics here in Jackson Hole, if you want to look him up. I think that's all we have for the night. Have a great night.
Thank you.